And let's get the waiting room open. Okay, here we go, everybody. Welcome, welcome. I'm watching the waiting room, so if you see me looking up, I'm just looking at that. We got a good sized group today. How exciting. I'm looking forward to this. I am Nan, and I am your technical support today. So I am here to provide virtual support for today's event. I'm going to give it just another second to make sure that we get everybody here and can hear. That chat is available, and in fact, if you'd like to give it a quick try, let us know where you're joining from. It's always fun to see who's the farthest. I don't count. I am in Chicago, but sometimes we get people from other countries even. So feel free to put in there good morning or good afternoon. I guess we're in the afternoon already here in Chicago. All right, hang on, got a couple more. That's awesome. All right, well, on behalf of the ACHE of Northern New England chapter, welcome to today's session. We are thrilled to have you here. I'm going to give a quick intro of some housekeeping things, and then I will be all done and we will get on to our event. Just so you know, you're muted. That's for purposes of noise control. We are able to come off of mute if at some point a question is asked and you would like to speak. You will be able to come off mute. So just so you know, you do have that capability. We are recording. That recording will be available in about 2 days, and that will be where you find the course for ACHE, where you registered in our learning management system. So keep your eyes out for that. You'll see a recorded button added so you can watch any of this again if you'd like. You also will be entitled to the 1.5 hours of ACHE virtual interactive education credit. Please make sure you're on for the entire event, and also please make sure that your name matches how you registered. And if for some reason it doesn't, let me know in the chat. I'll help you out with that. But that does take a little longer to post. It should be there in about 10 business days. So keep an eye out for that as well. It's usually sooner, but that might take a little longer. And let's see, evaluation, very important. You're going to see me put an evaluation link, in the chat numerous times because it is so important for you to go ahead and complete those. Let us know how we're doing, how today's event was for you. So it's a clickable link. You can go ahead and click it. It'll open a new window. We don't want you completing it, of course, till the end. And I will put it in numerous times, especially at the very, very end. So please make sure you grab that and take the time to complete it. Chat is open for, oh, good. I got a bunch of them in there. I'm going to go back and see where everybody is calling for or is joining us from. But the chat is open for questions and comments as well. So don't hesitate to put a comment or question in there. We will be moderating that. And we do have dedicated time at the end for questions. So just keep that in mind as well. All right, I'm going to go ahead and stop talking. I am going to turn to Christine. There she is, Christine Pillsbury from the chapter, who's going to get us started. Again, I'm Nan. I am here the entire time, and I am here if you need me in that chat. Just reach on out to me, and I will help you with whatever I can. Thanks, everyone, for being here.
Thanks, Nan. Good afternoon, everyone. It's Christine Pillsbury. I am the Director of Information Technology Services here at Monadnock Community Hospital. Been a proud member for almost 30 years. Excited to meet with all of you and share innovation and the changing face of healthcare delivery. Next slide, Courtney. I'm going to introduce our panelists and a little bit about them without reading their bio. I'm excited to introduce Dr. Andrew Watt, who's the Chief Clinical Integration and Transformation Officer at Southern New Hampshire Health. Thank you, Dr. Watt, for agreeing to be one of my panelists when I reached out and asked him to participate today. It was a quick, sure, what can I do? Happy to help. Next. And Diane Davis, my new colleague friend from Concord Hospital, the Director of Population Health. Again, building those connections and network. We didn't meet until this panel came to about, but certainly this new partnership and friendship is exciting, and welcoming you to our education committee in the future. So thanks for joining us today, Diane. And my colleague, Richard Scheinblum, he's the Executive Vice President and Chief Financial Officer. I've been working under his leadership for many years. Again, excited to have Rich here, supporting not only the financial side of AI, but also talking a little bit about the technology and his passion for security and other aspects of IT. So again, really this is about networking and connection and bringing these panelists and their seasoned expertise to all of you today.
And my name is Courtney Rice. I'm with the College of Professional Studies Online. I oversee health professions programs at the University of New Hampshire. And I will be a mini co-moderator today with Christine. Really, really excited to join you. Our brief agenda for the hour and 15, hour and 30. Our topic today is going to be AI innovation. And we're going to touch upon the relationship to policy, patients, public, and practice with our expertise on our panel. We will have some open conversations on the benefits, challenges, and misconceptions around artificial intelligence in our industry. We will have some integrative, interactive polling throughout. So we ask that you participate in that so we can share results. And then we'll finish up with about 15 minutes of a live Q&A at the end. We would like folks throughout the session to go ahead and put your questions in the chat, and we'll monitor that. We will answer those as we go through the session together. And if we don't get to you, we will make sure to address it at the end. Go ahead, Christine.
Great. So actually, we're going to start off, I think, Courtney, with a poll question. Let's start off with poll question number 1 for the audience before we jump in. And again, we won't read this for you, but we'll give you time understanding really how engaged are you currently with artificial intelligence, either applications in your role, in your organization, and are you meeting your organization's expectations? We'll give you a few minutes, not even, maybe a few seconds. They're quickly tallying, Courtney. Highly engaged, moderately engaged, somewhat engaged.
We also provided, so we know that some of our polling is a little text heavy. We want you to provide what your perspective is from your point of view, but we did provide a few definitions if folks want a little guidance on what we're looking for as we have these conversations. But it's not a hard and fast scientific poll. It's for the purposes of conversation today.
This is where I wish they had the background music button that I could hit so it would just not be silent. But it looks like we've got almost everybody's answered. I'm going to go ahead and give it maybe 5 more seconds, guys, and then we'll go ahead and end the poll. So 5, 4, 3, 2, 1. I'm going to end it. And let me know when you want me to share the results.
Yeah, why don't you go ahead and share those?
All right, here we go.
Interesting. Looks like we have a group who's moderately engaged, which would make sense. A group that's looking to learn a little bit more about how others are operationalizing AI or even just beginning the conversation. And it's okay to say a few of us are still somewhat engaged. And I think you're going to hear from our panelists today, sharing their expertise and insight. So actually, I'm going to start maybe with Rich. Rich, can you describe the innovations or any applications within AI that your organization has implemented and maybe the impact it's had to your day-to-day operations?
Thank you, Christine and Courtney, for inviting me to this panel. I'm pretty excited about that. I look forward to answering questions with Dr. Watt and also Diane. As far as our organization, I really think that we're in the infancy. What I'm working on now with folks within the organization is putting in what I would call foundational enablers that support the delivery. From my perspective, I see that there's a lot of opportunity here, but with all that opportunity comes risk, some security issues, and also we do deal with patients, so that we want to make sure that there's safety and there's also trust. So at this point in our organization, what we've done is we have an AI governance committee made up of, there's 2 physicians, a board member, nurse, folks from IT, me, where we've been going through the past 4 months, just getting our charter together. After that, what I see us doing is coming up with a process for people to turn in what I would call proof of concepts, which basically a process for, say, somebody wants to do something like ambient listening, for instance. And this is like sort of top on my list because we are going to be doing something with ambient listening. They'd have to turn something in to, so that show that they understand the technology, what the risks are, any compliance issues, things like that. As part of that, also behind the scenes, I'm working with my IT folks on security issues. I'd actually be interested in how many people feel that they have a good insider threat or a data loss prevention process internally. So we're working with some vendors just for example, I probably a lot of people here are familiar with KnowBe4. So I'm looking at tools that actually work like KnowBe4, but with technology so say if we opened up ChatGPT as everybody or Copilot or something like that, we would be that anything they do would happen in a web interface, and the software actually, which is AI based, would look for things like violations of PHI, things like that, and do education for the individuals. One of my concerns is just the whole educational component in somebody doing something that really puts this organization at risk. So again, for MCH, we're really at the foundational side right now. But I think once we figure out what we're going to do there, that will enable us to be able to look at some things to take advantage of administrative automation, revenue cycles, things, clinical decisions.
Yeah, you covered on quite a few topics there, Rich, but I'm going to ask Dr. Watt, to comment and share your thoughts, what's going on in your organization in this arena.
Yes, thank you. So thank you, Courtney and Christine, for pulling us together. So I would say that our organization is on the curve as to, Richard's point that he's starting to look at tools. We are, some tools we have widely deployed, others we're piloting. In our space, we are using AI tools in cybersecurity. We have opportunity for desktop tools that are related to our vendors. We are using some AI for meeting summarization. We have some tools that we're looking at that will overread radiology films. We have pilot programs in some knowledge AI tools. And I think probably the most transformational is we've done ambient listening.
Diane, what's going on at Concord Hospital right now in this arena?
So I will be truthful, answering the poll. I've been somewhat engaged in some of the work that we've been doing. As Rich and Andrew shared, we have developed an AI governance council with senior leadership and other key stakeholders. We've gotten some of our subcommittees in place to ensure technology, cybersecurity. We have very active engagement by our ethics committee. So they've been very involved in the products that we've already reviewed. And some of the things, very similar products that we have already started to review are that the radiology and the PowerScribe, some of the clinical documentation applications, and we have successfully rolled out ambient listening to over 100 providers. That has been a huge game changer. Very well accepted. Providers are finding this immensely helpful to that work-life balance.
Wow, that's quite the rollout plan for what you're dealing with. So really from a provider administrative standpoint, what do you think is driving this change? Where is that coming from? Meaning, what's the risk and benefit of the pressures that we're feeling? I know I'm feeling pressures in IT, certainly for AI, for implementing some of these strategies. So we're kind of in the middle here. We're here at the infancy stage here at Monadnock. Andrew, you're kind of rolling into it. Been there, done that, but still moving forward. And then Diane, kind of again mid-range. So does somebody want to comment your thoughts on the pressures that you're feeling?
Sure, I'll jump in there. So I think what's really important to understand is that, AI is not just in healthcare, it's in our society and it's transforming our society. So we sort of can't hide from it, because even if you don't actively engage, it will come into your organization. Patients will bring it in, providers will bring it in. So it's best to think it through and have the controls before it just sort of ends up in your organization, and you don't have the controls or the security or have sort of thought it through. I would echo Diane's comments that ambient listening has been an absolute game changer, I think, for the way we practice medicine, and I can only imagine it will continue to develop. That coupled with some other knowledge tools, meeting summarization, things like that, it is really sort of transforming. So I kind of go back to I think what AI is really doing is it's changing the way we talk to computers. Years ago, somebody invented the mouse. It was transformational in the way we deal with computers. And now we've gotten to a point now where, with large language models, we now have figured out a way that we can talk to the computer more natively and it can answer back.
And Christine, I just want to add a little bit more to that as well, because Andrew's making some great points around ambient listening. I took it a little bit further and actually talked with an N of one patient who had recently had an appointment with a primary care provider. And it was really interesting to get their perspective on this as well. They felt that it was it was such a changed environment for them, because their provider wasn't sitting there typing on their computer the entire time that they were talking. There was eye contact, there was conversation, and yet everything was being recorded and structured into the document, and nothing was lost. So, I think this is going to add significantly to patient experience and patient satisfaction as well.
Great. Courtney, you want to shift over to poll number 2 now? I think we're going to change the direction a little on the finance side now.
Yeah, and before I launch poll 2, it's important for the group to know that we purposefully didn't come in with a definition of AI for our panelists or for the audience. So in that spirit, I'm also curious, real quick before we launch poll 2, about, with the ambient listening as an example, any perceptions of the public, since AI is so hard to define even in this conversation, and ambient listening has been mentioned 3 times now as a process product that seems to work. Has there been any pushback in the public at all, or with patients, that you'd like to share? Or is that kind of a non-issue at this point? And then I'll go ahead and launch poll 2 after that.
I think I can jump in there. So I would say that this is an area where consent's important. And so before we use an ambient experience, we get the patient's permission, and we try to be as straightforward as possible that we're using an AI tool and it's going to listen to the conversation. And I would actually agree. I've heard similar things from patients that they feel like the interaction is better because it's more of a conversation. There isn't typing involved. Another thing I personally noticed is when you're flipping through the chart, you may get distracted and you might miss some key details, but the AI doesn't miss those key details. So it helps you not have to sort of say to the patient, "I'm sorry, like what did you say again about that?" And so I think it's really important. But it is important that the patient's aware that we're using AI and that they consent. I have not had a patient who has not consented to using, and that's just me personally. Everyone I've asked has been sort of okay with it.
So we do have the chat starting to blow up a little bit on the ambient listening. So I'm going to go ahead and pull a question from our audience, which is, are any panelists considering ambient listening or AI assist for nursing? Nursing is a big one. That's something that our group talked about in our prep, and other clinicians. So maybe Diane or Rich, if you want to comment on that real quick, and then there's one other question and we'll launch our poll. Go ahead,
Yeah,
Diane.
I know that Concord is considering the next rollout for ambient listening would be for nursing use. I'm not sure how they're going to define that in an inpatient, is going to be used anywhere in the inpatient departments versus our practices. That will be really interesting. I think the engagement is going to be high.
So where we are with it right now, and you have to understand to the folks that are on this call, is that we're a critical access hospital. So we're much smaller. Our resources aren't as wide as Concord in southern New Hampshire. So where we are right now is we're looking at the products, and then we're hoping into the fall to pilot that with 4 or 5 key physicians that have an interest in the products, get some feedback, and then kind of figure out how to roll it out to the wider group. As far as nursing for other areas, I definitely agree that there's probably opportunities there, but our first goal would be to get it out to our clinicians that in primary care and specialty.
Thanks, Rich. And I will ask this follow-up because Andrew actually mentioned this in our prep for this session. We have Pam who is asking about capturing accurate information through that tool and the review process for that. And I know that's something that this group expressed as a concern when we were prepping. So would anyone want to just add a quick comment about quality review of that ambient listening tool? Do you have any comments on that for our audience?
Sure, I can take that one. So it does not remove the need to proofread your documentation. It is just a tool, just like when we introduced voice recognition. We all know when you read a note that was done by voice recognition, you can tell who proofreads and who doesn't proofread. So it is my general recommendation. If you use Ambient, you proofread. But there are some things I think that's worth mentioning. So the first is that I found that ambient technology does a pretty good job of capturing full sentences, actually better than voice recognition. It makes sort of less typing errors, or if it mishears you, it can substitute a word that is not correct. Voice recognition sometimes misses a not. The patient's not having chest pain, and it says patient is having chest pain. The ambient, I haven't found those same kind of issues. And so I would even say that Ambient has expanded beyond just the patient interaction to the point that I often find myself talking to the Ambient system even when I'm out of the room. And so that actually saves me time because I'll go in, I work in the emergency department, I'll go in, I'll see the patient, I'll get the history, I'll come out, and I will actually be talking to the Ambient, formulating my plan as I'm walking back to my desk. And then I sit down, I place my orders, I proofread the note.
Thanks, Andrew. Rich, did you want to jump in real quick and add a final comment? And then Nancy, after Rich, will launch poll 2.
Yeah, not being a clinician, actually, one of my concerns, because even not having ambient listening in place for any of our providers, there's still some things that happen, such as like copying, pasting records, and then not reviewing those records. I still think that the education and also the need, these are highly educated people. They need to still use their critical thinking skills and not just rely on, what is put out in front of them. So that's, for me, some of it will be education as we roll this in.
Thank you. Nancy, can we go ahead and launch poll 2 for the audience if everyone could take a look? And we identified some things. We know we couldn't capture it all, so we put an other there. And if you could share what you think presents the greatest opportunity out of the choices, we appreciate it.
It looks like we have 37 that have answered, so give it a little bit more time, try and get that number up there. All right, I'm going to go ahead and I'm going to count down from 5, 4, 3, 2, 1. Let's end this poll. And here are your results.
Great. I think it's an overwhelmingly sharing those results, reducing administrative burden. We hear that a lot. I'm sure you hear that too, Courtney. I'm going to kind of shift our questioning to support that and ask you, Rich, how is AI impacting the financial practices of our organization, or even as we look at finishing our budgeting process? What are those priorities looking like when it comes to AI? Are you seeing that in this fiscal year budget requests?
So, as far as their requests, not a lot of AI sort of related requests, but what I'll tell you is that what I'd be looking for in the future is to start with some positive ROI cases. When we talk about administrative burden in areas like revenue cycle, there's even simple things that can be done with automation, like even in finance, for instance. I have a file that I have to produce, and I have a tool that I can just load the file in and it spits out the answer. It doesn't have to be a large language model for some of this stuff. It can be a little bit simpler. So and then, hopefully as we gain some traction with that in back office functions, things like that, we can reallocate those savings to be able to reinvest in clinical areas. I agree, like the 70% here, that I really think that the biggest opportunity for AI is on the administrative side.
Great. Andrew, would you agree on the
Yeah,
financial
I
side?
think if you look at most of the tools that have traction, they are in the administrative burden reduction category, maybe with the exception of some radiology tool. But again, that's a AI tool that overreads a radiologist's interpretation just to look for high risk conditions. I think that where we're seeing it is very hard to pilot some of these technologies because people talk and they're not cheap. And also, they're not all AI. Everyone wants to call their tool AI or their new version or their upgrade AI so that they can get some of the money. But I think one of the potential financial challenges is that when you move into these technologies and you begin to pilot them or roll them out, there's this overwhelming, well, I want it too, and we want to use it here, and we want to put it outpatient, and we want to expand. I think somebody even said, to the rehab group, to the nursing group, and so that I think is a potential risk. You have to sort of be clear and set. Even if you roll out to a particular provider group, all the providers are going to want it. So that's the big caveat, is you got to budget ahead of time and figure out what your actual cost will be. Otherwise, you'll be spending more than you thought you would spend.
I agree. Diane, are you seeing anything on the financial side of AI in your areas?
Really the couple of things that I learned about, just trying to find out some information as I'm not on the financial side of most of this, was product that we've been looking at for clinical documentation improvement application that will basically be a CDI AI assistant. And then another that potentially could help our providers with more accurate coding. So trying to capture coding just based on the visit, the active history, things like that. Coding recapture is a big deal as far as we're concerned too.
Great. So as far as hesitation, though, again, Diane, you shared initially that, you know, the early beginners of some of this, but do you see some hesitation with the AI in your clinical colleagues? Again, we have some innovators here at Monadnock that like the new shiny things, but is there anybody in your clinical colleague group that may be hesitant to any of the technologies?
I have not come across anybody who has literally just said, this is not for me. I think that it's been a more open, accepted thing. I think really getting through what Andrew described earlier with voice recognition, we've all gone that cycle. It's, that was a nice to have tool, not super accurate. Now that we're seeing, okay, this is kind of next step and we're seeing so much improvement, I do feel like that's had a really positive effect on people being able to accept them.
Right. Courtney, are you seeing anything in the chat that we want to comment on?
Well, I think I'll share a comment if it's okay, Adam, since you've posted it and the group might want to comment on it. Just reflecting back on our poll, and it may have missed not just improved diagnostics, but independently diagnosing medical issues and concerns. There's an agreement by all that most of the tools are on the administrative side, but as soon as the FDA and other governing agencies allow someone to start diagnosing issues with an AI, this Adam thinks they will come in droves and has seen some of these types of things in other countries like China. So is there, would anyone like to comment or reflect on that or piggyback on that comment? It was a good note to the group.
I mean, I can, at least from where we're at, that's like a really good point, I think, from adoption, because once things start to get approved by the FDA, then we're even going to get more pressure to do things. But one of the things that I read up on, it might be worth for people who are on here to look it up, is Gartner has this thing called the hype cycle, and they do one for AI, and it has different types of trends that are out there, and actually so that you can plan and when you can expect things to advance. A lot of the things appear to be anywhere from 2 to 5 to 5 to 10 years away from really having impact. So I just think that, people need to keep that in mind, especially in an industry like ours that's fraught with risk and statutory issues. I just think a methodical approach is probably prudent, especially we don't want to have any patient safety issues and things like that hurt people. We're in a high touch industry.
And it's interesting that we are, the big thing, FDA approval and sort of the freight train that starts after that. One of the things that we were talking about in the prep that I'd like to go back to before we launch the next poll is talking about clinical autonomy, because it somewhat references Adam's point too. And does this group think at present state or in future projections that AI will compromise or enhance that? And I would actually throw in some of the FDA approval challenges with thinking about that. Because one thing that Andrew mentioned in our prep was some of the concerns about the databases, some of the biases and inadequacies, and also lack of access to some of the most recent research and information, and how do you keep up with that? So would anybody sort of that's an open-ended cue to the group if you'd like to comment on that. I guess I'll start with Andrew because it's something that you brought up, Andrew, when we were prepping.
Sure. I'm not entirely sure where it will go. I think it's, kind of to Rich's point, it'll be a tool. We'll use it. It'll transform the way we work. And I think that it will probably remove some autonomy and add additional autonomy in other places. Someone once said that the typewriter would change the world, and well, it did, but it didn't change everything about the world, right? There's still a lot. So I think this is just one step forward. Sort of going back to Adam's point, I see that as AI diagnosing potentially sort of way out in the future. And I think that you have two major issues there. The first is that most AI today is not omniscient. It's a trained model. And typically you see models that are trained in images, and you see models trained in natural language processing or large language models. And so you would have to hybridize those two, and you'd have to have a system that could read medical records, look at data, look at the population you're treating, look at images that are generating. I think it's a stretch. I think that it would be potentially underwhelming if it just looked at words. So I've heard similar people talking about using virtual triage nurses where patients come in and they have sort of an ambient experience with some sort of a computer. Same kind of thing. There's some medicine that is based on the words, but there's other parts of medicine that are based on gestalt and appearance. And there's just so many variables that a clinician takes into account when treating somebody. I think AI is going to struggle in those nuanced areas.
I would just like that Andrew brings up an excellent point, because many of the models right now that we see operate only in one thing, as he said, whether it's vision or it's a large language model. What he's talking about is more a multimodal model, which we're a little bit of ways away from that.
Diane, any last thought on clinical autonomy or relationship with patients? I know you are a nurse. You were speaking on, the nursing industry in our prep. Any kind of last thoughts on that?
Yeah,
and
I think
in decision making.
just reviewing even our AI use policy, we've intentionally built into that AI is representing augmented intelligence. It does need to have human oversight. It does not take the place of clinicians and critical thinking and clinical judgment. And being very clear about that organizationally, I think, is going to be one of those ongoing messages, reminding people. Andrew's example of virtual triage, that would be, it's a tough one. It's not going to be 100%. And so taking that expertise, the clinical expertise out of that from the human touch, I think is I don't see that coming anytime soon.
Okay, and I am going to, Christine, ask one other thing that has popped up before we launch our other poll, which is the legal side of it. And Rich, you had some interesting comments when we were prepping about concerns about ensuring, liabilities and other things. Would anyone like to talk about concerns or maybe benefits? It doesn't have to all be negative on managing the legal side of some of these adoptions or changes within organizations, even if it's like finance. It doesn't have to be related to diagnostics.
Well, for starters, I think you should understand who your partners are and where the data is going that you're releasing, and what you're sort of what you're giving to your partners. I think that because that can cause issues in itself, depending on how they use that information. Because as Andrew said, these are trained models, I think that, the consent issue that Andrew brought up is extremely important, especially when it comes to privacy and security of people's information. And then, there's the whole ethics sort of piece of this, too, like using a tool to help with diagnosis, and it gives you like 6 choices, I guess, of how do you determine, the clinician's still gonna have to use their best clinical judgment to determine, so what's the best course of action? I mean, there's still that risk if you take the wrong course of action, you have medical liabilities.
Yeah, if I could jump in, I think that first of all, from the legal perspective, it's going to be challenging if we get to a point where the computer starts making diagnoses. And I'm pretty sure that that's going to be fraught with complexity. I actually have a hope that AI actually really helps and potentially avoid outcomes that could proceed to legal impact. So, for example, having early goal-directed therapy and early detection of deteriorating conditions, or there's a number of different things where AI may really help. Avoid missing critical diagnoses, things like that. Where again, it's augmenting the role, not replacing. I think if you start to talk about AI replacing, it's very problematic. If it's a tool, just like many other tools we have, I see that being successful.
And I think the big thing, I totally agree with what Rich and Andrew are talking about here. And I think the big thing for us is making sure we've got the key stakeholders at the table as we are reviewing all of this and introducing new technologies into the system. So thinking about, privacy and security and technology and data, regulatory, quality, ethics. Ethics has played, surprisingly, I was actually pleasantly shocked. It's really important if we're thinking about what the final outcomes are here, what we're impacting in our populations. We've really got to make sure we've got as many of these things crossed off so we have it as right as we can.
That's a great segue into poll 3. Nancy, if you could go ahead and launch that, because I believe it is the one related to governance. So let's go ahead and launch poll 3.
There you go.
And we know that there are challenges, and we know that we had to narrow our poll. So again, we took the liberties to make some choices, and we know that there are other nuances to this. But if you could pick the best one that applies to you, we appreciate it.
Sure, Courtney, our panelists will be able to speak to this, but our audience probably may want to select more than one area. Looks
Yes,
like
and please
close.
feel free to put any comments in the chat. We really appreciate those, and it stimulates more conversation on some of the nuances that we can't always capture in, a basic poll. So we appreciate it.
All right, I think we're getting close.
Yeah.
And
I'll go ahead. Yeah, it looks like we got almost everybody. So we'll close it in 5, 4, 3, 2, 1. Here I'm going to end it, and let's share the results. There we go.
All right, we're seeing bias risk mitigation and good old regulation and compliance at the top of the list. So I'm going to shift gears again. Rich started off talking about AI governance, but I'm just going to ask this group in no specific order. Are you finding innovation in AI outpacing the proven effectiveness in your experience? Meaning, how are your teams, think your staff, your colleagues, how are your teams dealing with this, industry, the development, the speed of development, the pressure to adopt it? Let's talk a little bit more about the innovation, because if we did nothing, healthcare would move forward. So we want the innovation, but we're talking about risks, fears, etc. Let's talk a little bit about that with this group. Andrew?
Sure. I love that poll. So I think that absolutely AI is outpacing, or development of AI is outpacing most controls. The state of California passed some rules, some laws trying to sort of control it, but it's developing faster than the regulations, and so it's certainly a challenge. I don't see that challenge going away. And so what we all need to do is, number one, you need to attend the lecture, right? So you're learning about it. You're learning about these risks, and you're thinking about them. We've all mentioned be proactive, have documentation, committees, policies, or charters in place. And then you also have to balance that with being open to innovation. I don't think you can just stay away from it. I will share that, I gave a talk maybe earlier this year on the ethics of AI. That is a big concern of mine, because as Richard mentioned, these are models, they're trained, they're as good as they are trained. And because they're being trained on imperfect data, they're going to have imperfect results every time. So for me, I answer that question as it's a bias problem, because we're humans, we make mistakes, we're training these models on imperfect data sets. Not everything is evidence-based. So to assume that these models are going to give the right answer is just not a safe assumption. So you need guardrails.
Diane, would you agree to some of that?
Yeah, absolutely. Again, it's as good as, I think, the oversight that we have on it. And I think, to Andrew's point, things are developing so quickly, it could easily snowball and get way ahead of us. So how are we being incredibly thoughtful in how we are doing this, as well as in our health systems?
So Rich, you kind of opened up the conversation earlier talking about security and infrastructure. So at the rate that the AI innovation is hitting our organization, what are your thoughts of making sure, we have the security infrastructure, or just general infrastructure, funded and implemented? What are your thoughts?
So, again, we're small critical access hospital, but I have had some interesting experience. For instance, last week I met with a vendor, and this is the thing where as Andrew pointed out, the technology is getting ahead of, I think, the regulations and the things that you really need to be aware of. So I talked to a vendor last week about something, and they've already rolled this stuff out to banking and other industries, not yet the healthcare. And when I asked about PHI, they said, we're working on that. Would you be willing? Can we pick your brain about what you think of PHI? So I think, if you go through and look at some of these tools, you have to be really careful, because as small hospitals too, or even larger hospitals, the whole vendor evaluation process, especially with something like this, is really, really key. There's a lot of a lot of vendors that say they promise they're going to do a lot of things. So I think that internal structure that you have, so that there's more people that understand how this stuff works and you can be as transparent as possible is important.
Great.
Christine, I wanted to jump in just because you all made me think about something that relates to that question, which is the sustainability, not only of the products, but the sustainability of the funding that you're planning to support those products and change management, which I know is an incredibly loaded question. Do you have just a quick thought on that piece of the challenges with sustainability or related to change management? Because Rich and Andrew, you talked about the development happening faster than the regulation. So new information is coming in that you have to have oversight for. Any challenges with change management that you've had that you might want to share, or challenges with sustainability that you foresee or you might want to share? Go ahead, Rich.
So one thing, I work in rural healthcare. So there's not a lot of money in rural healthcare. So that's some of the things that we struggle around. Even if you have money, then it comes down to, can you get that level of expertise and resource? So I'm hoping, at least for us, one of the things that, at least with this big, beautiful bill that I have, I'm hopeful on is the initial $50 billion or the $50 billion that they're going to be distributing to states specifically for rural healthcare. And I know that some of that is for technological transformation and also cybersecurity. So, and I'm hoping too that some of these funds that are coming in apply to our PPS partners, because they support rural healthcare big time. We deal with Concord Hospital, we deal with Southern New Hampshire. And I know that these tools and these things are not inexpensive. So I'm actually a little bit hopeful that some dollars are gonna flow through to us. Now, the process behind those, how they get distributed, we're going to be working on those things. There's no rules promulgated, but I'm actually hopeful over the next 2 years that I think the government is looking to transform some things, which also comes with its risks to our autonomy as organizations.
I think I'd like to add that this could potentially be a set of tools that is not equally distributed across a hospital community. Because what we're finding is that the AI components are often introduced through tools we use or vendors we've selected. And so I believe that, take, for example, our EMR vendor. So we're all hospitals, we all have EMR vendors, and we know that certain vendors are much further along in the AI curve than other vendors. There's some vendors that don't even support ambient listening yet. And so I'm not sure. I'm not going to go so far as to say that, there's a cost, but I suspect that you may find that in the larger, more robust EMRs, you're going to have more AI toolkits than you would in maybe a cheaper, smaller EMR vendor. So it may, not be equally distributed, and that may go to a sustainability.
Courtney, I want to jump in with just a quick question for Rich. Are you hearing from our board, asking about AI, or if this is a priority they are in our community from the patients? I'm not sure the patients are asking for it. They just want to have access to care. But has this come up at the board level, our AI conversation or discussions?
Yes and yes, not so much the individual patients. but more our end users and our customers, especially ones that we send to different conferences, like specifically associated with our EMR, or they'll go to some other national conference like HIMSS. They come back all excited with all these ideas. And this isn't like downloading QuickBooks on your home laptop that has AI capabilities within it. You really have to think through the ramifications and the safest way to implement these things. And I'm not just talking about clinical applications, I'm talking about non-clinical applications too.
True.
I have one, you keep prompting these ideas. I'm going off script for a second. Okay, so when in this discussion, can you talk a little bit about equity of care related to different types of populations in different service areas? On this topic, are we seeing vulnerabilities? Well, clearly it seems like we're seeing some vulnerabilities for the rural hospitals simply because of funding and resources, but I don't want to go as far to say that impacts care. But could we comment about equity from your purview and kind of population health from where you stand?
I could
Go
make
ahead,
a couple
Rich.
comments about it. Actually,
I'll come
go
to you,
ahead.
Diane,
You
too.
go ahead, Diane, since you're the population health expert.
Yeah, I think, with the previous question, even I was thinking about the impacts from our payer perspectives as well. And how much are we getting pushed through our payer contracts to get more actively involved? Or, how much quicker are we collecting a much broader data set that will help us with our clinical and our clinical quality and utilization data? And kind of what's that worth to them? I think that we're still going to find that there are significant inequities. Just thinking about, we've got Franklin Hospital is the critical access hospital as well. And so I get where Rich is coming from, and you really got to be kind of cautious about what you've got for budgets and expenditures, and then how well is it going to be accepted? And thinking about the populations you serve. What are the needs? The needs are very different when we're looking at Concord versus Laconia versus Franklin. So I don't think it's a one size fits all from an equity perspective.
Yeah, I would completely agree with Diane, especially on the data. Remember, you're going to be feeding this thing to whatever it is. It's going to be probably information is going to be coming out of some other system, and it's only going to train itself as good as the data is. So also, and we don't have very good data governance in place. So for me, it would concern me, getting to Andrew's point about biases and things like that, that if the data is garbage going in, your model may have biases. There's been in other industries, like in banking, for instance, where they might use an AI tool to produce, like, to qualify people for loans. There's actually been case studies where they take the data that they've used to train the model to determine if somebody's eligible for a loan, where you might have had a loan officer who in a certain area of a town, because of demographics or whatever reason, would not give loans. So the model gets trained on, which also could create legal issues for you too. So I'm not thinking that we have an issue like that, but you never know. You have to really watch this and have some place, especially with the clinical information. I'm looking at Dr. Watt, that clinical validation, I think, would be so important, especially when we're dealing with patients, if you're using it to make decisions.
Yeah, so I agree with everything that Rich said. I think it's important to note that while some of these tools are directly patient facing, Some of them are not, and I think we shouldn't lose sight of that. So, just some of these tools that, we can use to summarize meetings or to do research. And I think that there's some general things that can help. So, when you're looking at these products, they are typically provided through your vendors. You need to ask what model they're using. I think, traditionally want to look at closed models, which basically means that they've been trained, they've been validated, they're not open, they're not continuing to read the internet for data. And then you can actually get some models where they have a model, and then locally that model may run with your data, but not share or make memories from your data. And so that may be a nice bridge as we get closer. I also think that computers are advancing, exponentially. If you look at the iPhone 1 to the iPhone 15, it's a totally different device. And so I think what we'll see is that the technology that makes this AI computation will get cheaper and easier, and we could begin to start to localize it. So right now we can't. These are giant data centers that run this, but there is potential that you could train a model and then install it locally on hardware that you have in your data center, and potentially just chew on your data and not make broad sweeping assumptions. That may be the best way to control bias. I'm not sure.
Actually, Andrew brings up a good point, because the other thing that once you do something too, it would be nice to know too how people are using tools. I mean, not just say something like, the ambient listening or some actual application, but one of the things that I would like to do is to be able to start with something like Copilot, okay? Open up Copilot to everybody here in the organization. I'm looking at a tool now that I could take all the information and classify, say, physicians, nurses, people in finance, so on and so forth, so that we can make better decisions about future tools and see actually how people are using this. That's the other thing, like the whole visibility and transparency piece of it. Having some sort of tool to understand how your folks are actually using these tools, I think, is really important too.
That's incredibly refreshing to hear, honestly. And it sounds like a basic principle, but it isn't always put into practice in a lot of the big industries, not just healthcare. So it's really refreshing to hear you say that. We do have a question in the chat. If you don't mind, I'm going to interject that. And it's going back to some of the payer comments. Shauna was asking or making the suggestion, with insurance companies wanting us to use AI, shouldn't they help pay for it? And does anyone have a thought on that? Either an innovative thought or a concern or just a general comment. Thanks, Shauna.
Yes, that's my thought. Yes. I totally agree with Andrew and Rich, and things are going to, this technology is going to get cheaper and more broadly used as it continues to develop. But for right now, things are really expensive, and never mind just the technology, but you have to think about the people time behind that. Everybody involved, as I was saying earlier, all the key stakeholders that you have in your system to make these decisions in the first place. There's a lot of time, people time, intelligence to review. So it isn't just the cost of the technology itself. And I feel like, yes, they've got a stake in this. There's a lot to be said with meeting quality and utilization and contractually agreed upon targets and outcomes, and potentially being able to have some incentive from that. On the flip side, we do get penalized as well. That's kind of the ongoing saga of, from CMS down. So should there be an investment on this or that side? Absolutely.
Rich, you unmuted. Did you want to add anything to that?
I think that that's an easy question, an interesting question with the insurance companies. I think what we're going to see is the investment probably come from CMS, initially. Having worked for an insurance company way back, and then I do the contracting, I'm responsible for the contracting there. They have very sophisticated tools, and I can tell by the information that they're giving us. Unfortunately, we don't have access to all the insights. The only place that I've seen, and Diane could probably speak to this as Director of Population Health, the only place where I'm getting really, really good insight right now is through our ACO. Because we get all the Medicare data, no matter where a patient goes. So that the problem is if we just made decisions, probably from a patient care standpoint, based on only Monadnock Community Hospital data, there's a lot of services we don't provide because we're a critical access. But it's nice to know where people are going to get those services and who we could have for potential partners. So, I'd start with if you're in an ACO, start with your ACO and Medicare data. I'm not expecting the insurance companies to hand over a lot. They'll be forthcoming.
Do you think we have a little bit of time left, Christina? I know you're going to ask a couple final questions. We've got one poll left. I think we have time for this. Any thoughts on where that's going to drive value-based care for better or for worse? So I'm actually thinking about these AI models. I'm thinking about the insurance company investment. Again, I'm going off script here, so I apologize. But is anyone have a thought on that? Even a prediction? If it might help, hurt, make things more challenging in terms of patient care?
I think from a standpoint of using it to analyze the data, not necessarily tell you like diagnosis and things like that. I think that there's a lot of opportunity to load data in to look for trends and things like that, and utilizing it to determine who are your highest risk patients that could cost your ACO or plan the most, things like that. Like that's where I really see the opportunity, not so much on the clinical decision making side of this time.
Andrew, do you want to add a final thought since you've talked a lot about the clinical decision making side? Any thought on that and some of the insurance company stuff?
So I think I largely agree with what was said. And I think that the real advantage that I see on AI is really the semantic processing. It's the ability to sort of understand a question. So potentially, it will help folks who are trying to close care gaps by reading documentation and potentially closing those care gaps by finding events. But I think Richard's point is valid, which is it's only as good as your database, and CMS, it has the data. So I'm not sure that Monadnock Community Hospital is going to be able to get further without CMS data. So it'll be interesting if someday they train models on those kind of databases, but I don't see that happening anytime soon. So
thank you.
Thanks, Courtney. Again, we wanted to make sure we get about 10 minutes at the end of the session for some Q&A. We're doing great on time. We do have one more poll, but I just wanted to pause and reflect myself as I'm hearing a lot of this dialogue and conversation. You have 3 seasoned experts in healthcare, financial, clinical, security, IT, and even hearing them not have all the answers. And I think that's one of our takeaways. We've discussed so many different topics. And if your heads are spinning a little bit, that's okay. Again, having access to this panel here today has been extremely helpful. But I do want to take a moment to finish with poll number 4, because I think that can close up with our session today and then allow for some greater conversation, if that's okay, Courtney. And that's really, what is your biggest concern? What's our audience and what's your biggest concern with AI? Again, going back to the clinical practice. So we'll just take a moment. There's no right or wrong answer, but it's great to see over 55 of us here today, this afternoon. I know everyone's super busy, and I'm not the only one with enthusiasm for AI, which is a good sign. All right. Look at that, Courtney. We're seeing we have data privacy, bias, loss of human touch, and training and trust. Those were our answers. I think we're getting close to end that, Nan.
Okay, let's go ahead and close it in 5, 4, 3, 2, 1. Here we go. And here's your results.
Great. We got bias and loss of human touch. I actually would love to get a little more reflection on the loss of human touch. We talked a little bit about actually rewarding using AI, ambient listening in the clinical practice, how patients were responding, N of 1 to Diane, liking that experience. But let's talk a little bit about that before we go into our Q&A. Diane, do you want to speak to that? The audience thinks loss of human touch.
I would suppose that I'm probably not the best one to answer this question.
Yeah.
I do feel that to some degree that are people going to be influenced as the on the other end, on the patient end, on the receiving care end? How much do they trust that those clinical decisions are being made by the clinician in front of them or virtually meeting with them versus some of these AI tools? So I definitely could see it from that perspective.
Right. Andrew, anything that you're seeing in the clinical practice?
No, I generally agree. I think the comment from Spear that patients seem to sense more direct interaction. I think maybe the biggest threat has been social media for the loss of human interaction. I'm not sure AI. So I would not have picked that answer. I picked a different answer, so I'm not the best person to ask.
No, that's okay. Rich, your
I,
thoughts?
ac- I actually picked that answer
Good.
about the loss of the human touch. And I can only speak, for my experience with my organization, and then when I speak to others about this, but our mission is to improve the health and well-being of our community. One of the things that drives me nuts, and I don't know if it drives Andrew and Diane nuts, is when I go into a meeting and we talk about AI, and right away people start saying we have to have an AI strategy. Like, that's not what we do. AI should be a more tactical to support our mission in our strategy of delivering care to the patient. So that's kind of how I approach it. We're not an IT company. That's just not what we do as a small house.
Right. I think there was an interesting comment from Anne. Courtney, do you want to read that for the group?
Yes, a few comments coming in on this last portion. The last comment from Anne, I think it's our job as healthcare leaders to leverage this advancement to the extent possible without negatively impacting the human-to-human connection that is unique to our work, because we are a human ecosystem. So that's a great comment, Anne. And then there were a couple other comments. I was just scrolling through that at Spear. I'm going to scroll up here. Hopefully I pronounced that correctly. Lisa was talking about that patients love the direct communication versus having a provider type while talking. So there are a lot of nuances to that human in the loop, and more folks are adding comments. Let me just see. Again, Lisa, it's been good for our providers to get their documentation done at the end of the day, not have to take work home. So we haven't even touched on human ethos of providers and the burnout that exists there. So thank you, Lisa, for that comment and reducing the onslaught of incoming portal messages and paperwork, which was another thing that we didn't have time to address today, but that's a really great comment. So more things coming into the chat that people can read. I think at this point where we've got 10 minutes or so left, we can open the Q&A to the larger group. We do have some follow-up questions, but we want to make sure that folks can participate fully. So we're completely fine with people raising their hand as well or jumping in. We'd love to hear from you. But if you're not comfortable doing that, please go ahead and put any additional questions you may have in the chat, and we can address those now. So we'll just give it a minute. And also, if people just want to have a comment, is fine as well. We've had some excellent comments in the chat.
I'll actually jump in with a comment, Courtney. You started sharing a lot of these topics. We didn't have time to get through. I think, again, it demonstrates the need and the excitement or curiosity about AI and how our organizations are implementing, thinking about it, utilizing that. So again, like I was sharing with Rich earlier, we could easily talk 2 hours for these sessions, but we want to be respectful of time and have this be organic and, what's on your mind. And maybe if there is additional interest for ACHE to maybe do a 2.0 in 6 months or so. And it's hard to say no to Christine. So if I ask our panelists again, I think might be some volunteers. Is there anything?
We do have a question from a little bit earlier. So I was trying to track it all. And Anne had a question going back to ambient listening. So this is a little more specific question, but she was curious about, she was thinking about ambient listening, or Anne, correct me if you already are using it, but thinking about it for the outpatient therapist. So kind of looking at different applications for that. Does anyone have a comment on different applications for maybe that group that we haven't specifically talked about today? Diane, I see you nodding, so I'm going to go ahead and just ask you to make a comment.
Yeah, that's a really interesting question. And I think that probably one of the bigger barriers or obstacles for that would be because we have not yet, I don't think systematically across healthcare, accepted that mental health is actually part of whole person health. And I think there'd be a lot more resistance on the side of patients, people with mental health issues, behavioral health issues, and utilizing AI with a therapist, although virtual visits are incredibly common now. So that would be a tough one.
That's an interesting question, because we started this COCM program, and I don't know what the acronyms stand for, but we've been looking at some information to track data. And I think in the mental health area too, there's limited data sets. It's my observation. So, an inconsistent probably data sets. So I don't know what the application would be. There's probably things out there, but then it comes back to the data that you might have for your population.
That's been a huge theme for today. And I think I'll go ahead and ask, I'm not seeing hands raised. So please, people, unmute and just interrupt me if I'm not seeing it, because we have a great number in our audience today as we wrap up. But since we're talking about interdisciplinary now, would each of you have a thought on interdisciplinary approaches to this work? And I know that that's also a broad question, but just maybe a final comment of how, what interdisciplinary type approach you're taking in your work, or things that we should think about as an industry working more in an interdisciplinary or interprofessional context related to some of the information that we talked about today. Go ahead, Andrew.
Yeah, so I think that I'm thinking the approach is systematic, and to your last question about therapists. So I'm not sure if it would work or not, but I think you have to approach it open-minded, give it a try, see if it works, see if it doesn't work, and see what sticks. I think as we mentioned, this technology is not limited to healthcare. It is throughout our society. Everyone's going to be using it. We see patients coming in using ChatGPT. Like we don't really know. So I think that you just have to be open-minded to this approach. I actually think of televisits, where televisits was a technology that really didn't catch on. Then COVID hit, and we transformed our organizations overnight to do a ton of virtual care. And now, if you go back, you find out that, it has been very successful in behavioral health areas. It's still doing very well in that space, but yet, you don't see many surgeons that prefer to do telehealth. So I think that's a kind of interesting thing. I think it's an emerging technology. I think it'll be interesting to see how it's used by people in general, and I think that'll drive the hospitals. And so just be open-minded, approach it, and evaluate tools as they come in.
Any other final thought on that? And we have one final thought in the chat, and then I'm going to hand it over to Nancy to wrap up for information about evaluation and credit. Richard, Diane, did you want to add a final comment for today?
My only recommendation was start small and build momentum. That's at least what we're trying to do here. I think what we'll start with is some small pilot projects. Again, we're not doing a lot. I only know really of one thing we're using in security that's AI based. The whole change management, Andrew mentioned that is extremely important. I can't tell you how many times we introduce something and it messes something else up in the technology world. The governance, I think, in having a interdisciplinary committee made up of a variety of different folks from different backgrounds is important. I'd start with those.
Thanks, Rich. And Diane, any final comment before we hand it over to Nancy?
Yeah, I think, reflecting on what's been said, I think that even just the model of an AI governance or collective kind of think tank in our organizations is part of that interdisciplinary approach as well. You've got a lot of different disciplines around the table helping to make those decisions. And the other thing I would say is just, Richard said much earlier, what's our mission? Remembering to stay mission focused. This is not about AI running the world. This is about how are we approaching healthcare from a people perspective and utilizing it to augment what we do.
Thanks, Diane. So Nancy, we're going to turn it over to you. Christine, did you want to do a closing
statement? Just a few closing comments. Yes, I just wanted to thank our three panelists for agreeing to visit with us today. I found it extremely helpful and interesting, but I also wanted to give a shout out to you, Courtney, for helping be my co-moderator for those ACHE members that are either new and up and coming or seasoned. I encourage you to participate in your educational sessions. This was my first time moderating. I've been an ACHE member for many, many years and getting outside my comfort zone. So again, one of the value adds of ACHE is taking advantage of these opportunities. But how fortunate were we today to have Dr. Watt, Diane, and Rich joining us. Again, without hesitation, it's their commitment to healthcare leadership. Small community, large community, hospitals, it doesn't matter. I think the takeaway for me is doing nothing is not an option, and you're all here to understand and learn from each other, and I applaud all of you. So thank you. We'll turn it over to you, Diane.
All right, thank you. Thanks, Christine and Courtney. Outstanding session. Wow, I don't think I've ever seen the chat that busy in something that I've been moderating. So Thank you, though, on behalf of ACHE, on behalf of our chapter leaders, on behalf of everyone that put work in today, our moderator and our panelists, and thank you to you for participating. Again, that evaluation, I'm going to put it in there, but it's getting buried by lots of thank yous and praise. So you can try and grab that. It is available where you find your courses for ACHE on the learning management system. So if for some reason you miss it, please go there and grab it. That's where you'll also find the recording, and you'll also get your 1.5 interactive ACHE interactive virtual credits. We'll post there. It takes a little longer, should be there within 10 days. Again, thank you so much to everyone. It concludes our session. It is copyrighted in 2025 by the American College of Healthcare Executives. All rights are reserved. Thank you, and enjoy the rest of your day.
Thank you, everyone.